Good evening, everyone. On behalf of AP Society of Nephrology, we are privileged to have Dr. Sanjay Sinha, sir, and I am the student of Usmania. We are eagerly waiting for sir's lecture since 8 years, and I have prepared all the case material for sir on urodynamic studies to discuss with the sir, and I am eagerly waiting for his lecture. I welcome Dr. Sanjay Sinha, sir, Apollo Hospitals, to enlighten us with the urodynamic studies and also evaluation of urinary bladder in case of urinary tract infections and urosepsis. I welcome you, sir.
Thank you so much, Dr. Sahivani, and my apologies for having been so difficult over the last few months, at least when you were trying to set this up. So let's get straight onto the subject here. And my plan is that I'm actually going to speak in a formal presentation just for a few minutes to give a little bit of a background so that everybody has some basic information before we start off. But otherwise, what I thought was you've got, can you hear me?
Yes, sir. Yeah. And sir, 1 minute, sir. I request Professor Shivakumar, sir, Emeritus Professor from SWIMS, and Dr. Chinta Ramakrishna, sir, from Guntur, to chair the session. Shivakumar, sir.
Okay. Right.
Chinta Ramakrishna, sir.
Yes, sir. Please go ahead, sir.
Yeah, so my intention is to just give a little background over the next few minutes about urodynamics. And then Dr. Saivani has some excellent case material with her. And I think we would learn much more from each other from the cases rather than from giving a didactic lecture. So let me just quickly share my screen here. Okay. Okay, so can you see my screen now?
Yes, sir. Yes, sir.
Okay. So what I'll do over the next few minutes is just run you through what a urodynamic study is, what are the basic findings that you can get. And at that point, I'll stop and we'll go on to the cases. Okay.
Okay.
So just a moment. So this is what a typical trace looks like. So before I start, when you look at a when you discuss urodynamics, there are two different skills. One is a technical skill of doing a test, and the other is a clinical skill of interpreting information. So we are not getting into the technical aspect at all. So I'm not going to show anything about how to do a test. It doesn't make any sense. Okay. Even if you were to ask me how to do a test today, perhaps I haven't handled a machine for the last 15 years. I would find it difficult. So we're just going to talk about the clinical interpretations. So this is what a tracing looks like. Okay. So the top line is vesicle pressure, abbreviated as PVES. The next line is P abdomen, the red line. We often put red for rectum, you could say. And P det is that third line here, which is the subtracted pressure. So if you subtract abdominal pressure from the vesicle pressure, you get the detrusor pressure. Now, why do we do this? This is because if we have any movement in the body, coughing, straining, walking, talking, laughing, the abdominal pressure goes up. And this pressure that goes up is reflected not just in the abdominal pressure trace. Even if you measure pressure from the bladder, you see the same rise in pressure from the bladder as well, because the bladder is ultimately within the pelvis, the abdomen and the pelvis. Okay, in the same peritoneal cavity. So to be able to find out how much pressure is exerted by the bladder wall, you need to subtract these two. And that computer-based subtraction line is what the detrusor pressure is. It's conventionally abbreviated as PDET or detrusor pressure. Okay. The third line here that you see here is the flow. So this is telling us what urine has been passed or leaked, as the case might be. This next line is void volume. So this tells us how much urine has been passed or leaked. Volume filled is the amount that has been infused. And this is the EMG line, which you may or may not find in many of my tracings, because these days I rely lesser and lesser on the EMG. So this is the timeline. You can see right at the bottom. And you can also see here the volume that has been filled. So you can see we are filling the bladder, and that's the amount filled in. And as we are filling, we are recording the pressure. Okay. So that's the time. This part of the study, up to the place where the command to pass urine has been given, is called the filling cystometry. And then from the part where the patient has been asked to pass urine, we can call it voiding pressure flow. So in the filling cystometry, a normal bladder will store at very low pressures, close to zero. You don't find any phasic contractions. So if you have a low pressure, there's no rise, either phasic or progressive. The normal bladder capacity is dependent on age, etc. But in an average adult, you would expect something 300 ml or 300 ml plus. In children, there are certain formulae by which you can calculate how much to expect. Okay. Normal sensations would be characterized by a first desire, a normal desire, a strong desire, and then the patient may say, I just can't wait, at which point we ask the patient to start voiding. That's the micturition command. And when you give a micturition command, that's the micturition command. What you find is that when you tell the patient to start passing urine, the EMG tends to become silent before the start of the detrusor contraction. So the first step in the process of passing urine is not the bladder contraction. The first step is after the brain initiates or gives a command to the pontine micturition center. The first step in the micturition process is relaxation of the outlet. So first the outlet relaxes, the bladder contracts, and then once a certain threshold pressure is reached so that the outlet can open, then after a few seconds, you'll find that the flow starts. So there'll be a delay, there'll be a time lag between the start of the detrusor contraction and the onset of flow. And then the detrusor pressure takes a peak, typically an eccentric sort of a bell-shaped curve, and you get urine flow out freely. And a normal flow is characterized by urine coming out in what we say is sort of the normal time at a normal rate, and the bladder should empty completely. Now, there's some things before I go forward which we look for in a good quality trace. And why is this important? Because unfortunately, it's very easy to do a poor quality test. And quality control is an issue even at academic centers. We've seen that, not by we, I mean, it's been published that even in academic centers, there are a lot of issues with quality. And if the quality of the study is not good, then it can lead to trouble. So let me give you a simple example off the cuff of a patient who happens to be the daughter of a professor in the medical field in the US, in an Ivy League university, where this daughter had a tumor in the pelvis, was operated, developed a neurogenic lower tract dysfunction, had urodynamics, but now in retrospect, when she sent the traces to me, these urodynamics which were done in the Ivy League university were all of atrocious quality, not picked up, not managed correctly, is an end-stage renal failure, which should never happen for something which is completely preventable. But nobody was able to pick up the quality. So it's important to understand quality. So here, what are the quality control things that we are looking at? The resting abdominal and vesical pressure should be a finite amount. It should not be starting at 0. So your P-det starts at 0. But there is a certain amount of pressure that is there within your abdomen, and that should be reflected in the initial resting pressures that you're looking at. Step one of the first point of quality control. Second, when you look at there should be cough spikes during the test, typically at roughly a minute intervals. And when you see these cough spikes, there should be a reasonably good subtraction. So you expect that if there is a cough, the pressure rise within the bladder, detected within the bladder or detected within the abdomen from the rectum should be similar, and they should more or less subtract. So we expect about a 70% subtraction. It may not always be there, but you should get a reasonably good subtraction. That's the second quality point. Third, and this should be done through. So you should find it every minute. You should find it at the time of giving the command to pass urine and at the end of the study to make sure that the transducers continue to work correctly right up till the end. The third quality control is looking at the fine pattern of the trace. So if you look here, there's small deflections that you see in both these lines. These small deflections may represent the patient talking, the patient breathing, moving around a little, and you expect these to be there. So it tells you that these signals are live all the time and they should be subtracted. You should see them on both. So these are some quality control. You should not see a drift in the abdominal pressure downwards, which you can sometimes see if the abdominal pressure is not, probe is not working correctly. And finally, because the P-det line is a reflection of the bladder pressures, you can't have a valid change in P-det without a corresponding change in the vesical line. So if you see any rise in pressure, let's say during filling, you see what looks like a phasic contraction, you should be going back to the vesical line to see, are you seeing a corresponding rise there? If you don't, then it's because of some artifactual changes in the abdominal pressure. Okay. So let's take a look at some, what you can say, artifacts in terms of quality control. So you can see here, this is a patient in whom there are what looks like phasic contractions during filling. But if you look at the vesical pressure line, there's no change there. So clearly, these changes in pressure are not phasic contractions. They are because of something happening at the abdominal pressure line. And you can see two things happening at the abdominal pressure line. One is you can see that there's some spontaneous rectal activity. And the second, as you can see, there's a general drift down in terms of the pressure, rectal pressure. So it's going downwards. And that's reflected in what appears to be reduced compliance on the bladder, which is not true. Because if you see the vesicle line, it's holding steady at the same flat level. So there's not much of a change actually in pressure. All these changes are artifacts. So it's not diffuse overactivity and it's not a poor compliance. Similarly, if you fill very fast, then you can cause the pressure to spuriously rise. So it may look as if the patient has a poor compliance because ultimately the bladder wall has certain biological limits. If I fill it at 100 ml per minute, for instance, even in a normal bladder, there may be some rise in pressure which would not normally happen, right? So here you can see there's a very sharp rise in pressure depicting poor compliance, but the moment it stops filling the bladder, you can see even without any urine being passed, the pressure drifts down substantially, comes less than half of where it was. And this accommodation in pressure tells you that this patient actually, we've been filling too fast because this shouldn't happen. So much of an accommodation is telling you that the filling was too fast. And that you're seeing a spurious rise. So this is a poorly compliant bladder, but it's not as bad as the pressure is depicted here. Okay, now let's take a look quickly at some findings. So if when we are looking at voiding phase, then in the voiding phase, you can have a patient, the patient can either have an obstruction or an underactivity if they're abnormal. So obstruction means I'm trying to push the door is jammed and hence it's not opening well. Underactivity means I'm trying to push open the door, but I'm not pushing hard enough and then hence the door is not opening. Okay. So take a look at this study. And in this study, you can see when the command to void is given, this appears. So don't go into the numbers. There's a very high pressure here and there's a slow flow. So if I've pushed very hard against the door and the door has opened slowly, the door has got to be jammed. The only other question might be at where is the door jammed? And that can be crucial in certain situations. So this is a young man, and you can see here in this patient on the video, play again on the video, you can see here that the bladder neck is not opening well despite that very high pressure. And so this is a primary bladder neck obstruction. Okay, take a look at this woman who's again presented with a high pressure and a slow flow. Again, you can see here the pressures are high, the flow is slow. We won't go into the details, but in a woman, these pressures are different because the woman's voiding physiology is very different. Many women void with apparently no detrusor contraction. That's not really true. Most of them are voiding, many times women void with relaxation of the outlet and just the weight of the contents of the abdomen is enough to drive the urine out. But if you were to give a resistance, you would find that the bladder is actually contracting. So because what we record as a pressure is not just a function of how much contraction is there, it's also how much is the resistance. If there's no resistance, you don't see a pressure rise at all. So this again is a primary bladder neck obstruction in a woman. Yeah. Now this is another patient who's obstructed, but the obstruction location of the obstruction here is different. So you can see here a relatively high pressure, relatively low pressure in a woman, and you can see that the urethra is dilated. So if you have a urethra dilated during the study, that tells you that the obstruction is not at the bladder neck, and anyway, bladder neck obstruction in a woman is a rare phenomenon. So this obstruction is mid-urethral. This can happen either because of a dyssynergic sphincter, or you can get exactly the same picture sometimes in a distal urethral stricture. It may look exactly the same in anatomical stricture. Sometimes you can have patients who don't void urine at all. So this is a woman in whom there is no voiding at all. When you try to make her pass, there's no contraction. She doesn't pass, but she's not in retention. So if a patient is not in retention and you get this kind of a picture, we've always got to be suspicious because this may not be representative of what's happening. So if I'm very nervous, there are 20 people watching what I'm doing, or I'm in discomfort, I may not be able to pass urine. And that doesn't necessarily mean that my bladder is not normal. So this lady was passing urine, but she had a history of marked urinary difficulty in passing urine. And you can see here, even on a video, there's nothing much seen because when she's not passed, there's not a drop of urine coming out. The urethra is obviously not dilated. So in all these patients, we do what's called a video uroflow, and you can see a hint of urethral dilatation here. And she had what we call a high tone non-relaxing sphincter. So in some women, just the outlet resistance is so high that the voiding reflex does not initiate. And you can pick this up on something called a urethral pressure profile. So it's a form of a dysfunctional voiding where the sphincter is not relaxing and the woman is not able to pass. And this kind of a patient responds very well to sacral neuromodulation. So for women like this, now we would offer sacral neuromodulation with almost a 75% success rate of getting them off CIC. They would pass very well with it. Now this, on the other hand, is a patient who's not passing well, but you can see here that the contraction pressures are very low here. So a bladder which is pushing with a very gentle contraction is not able to really generate a good pressure, and the flow is slow. So we always make a diagnosis of obstruction or underactivity by looking at both of these. You have to see how hard did the bladder contract, and you've also got to see how fast did the urine come out. Because in isolation, you may find that the bladder didn't seem to contract well, but if you have an excellent flow, the odds are that the bladder is perfectly fine. Okay? But if you get a slow flow and a low pressure contraction, this is an underactive detrusor. Okay. Now let's take a quick look at storage abnormalities. And I told you in the beginning that a normal bladder stores at low pressure. So when you fill the bladder, you shouldn't get any rise in pressure. But here you can see on that third line, the PDET line, that the pressure shows rises. And you can see these phasic rise and fall. This phasic rise and fall is called detrusor overactivity. And this woman leaks at that time. So this is detrusor overactivity incontinence. So this often manifests as urgency incontinence. Okay. This is another woman in whom there is a urinary leak, complaint of urinary leak. And here you can see there is a phasic contraction, but she doesn't leak. And then when we make her cough and all these spikes her cough, you can see that she's leaking here repeatedly when she's been asked to cough. So this woman has urodynamic stress incontinence because when she's coughing, she's leaking urine. And sometimes these women will not leak until you remove the urethral catheter. So you can see here at this point, the urethral catheter is removed, so the pressure suddenly dropped to 0. And after that, she leaks when she coughs, but she doesn't leak before that. But ultimately at home, when she's leaking, she's not got a catheter in the urethra. So if there's a history of urinary incontinence, you're not able to find it, then you need to remove the catheters and retest in the standing position, because that's how women mostly leak. And then when you make them cough, you will be able to unmask the stress incontinence. This is a woman who's got both problems. You can see here a phasic contraction and a leak. And you can see here when she coughs, she leaks as well. This is a good slide to illustrate another point. When women leak because of urgency incontinence, which can often show detrusor overactivity, this leak is usually high volume. And you can see that high volume depicted here in the pattern that you're seeing on the flow channel. You can see a much larger amount of urine coming out. You can see that the bladder is almost emptied at this point. Whereas in the stress incontinence, a much smaller amount of leak. So the first thing this tells you is detrusor overactivity incontinence tends to be larger volume. So women will say, I got an urgent feeling and I flooded my clothes. So that's classical of urgency incontinence, but stress incontinence, they'll almost never give you that history. The second is you can see it's prolonged. So you can see it goes on for a long period of time. Stress incontinence usually doesn't happen that way. The incontinence happens as a spurt at the time of rise in abdominal pressure. And the third thing which doesn't show up here is that the urgency incontinence associated with the detrusor overactivity incontinence is unpredictable. It can happen while we are sitting and talking, and hence it's much more bothersome to patients. You can also get something called cough-associated detrusor overactivity incontinence, where you have the phasic cough will trigger a contraction, and that causes the leak. And this can mimic stress incontinence, but it's actually, depending on the type of CADO, it's often an urgency incontinence. And you don't really need to go into the details of this, except to say that when you do a stress test to make the woman cough and see whether she's leaking or not, the leak doesn't start and end with the cough. When the woman coughs in the lithotomy position, you find that the leak starts a fraction of a second after the cough and continues beyond the cough. And that tells you that this is likely to be urgency incontinence associated perhaps with the CADO. So we'll now lastly take a brief look at neurogenic dysfunction. And in neurogenic dysfunction, the important thing to remember is that lower, even for non-neurogenic for that matter, that from a nephrologist's perspective, the storage pressures are much more crucial than the passing pressures. So this is something that we have published in 3 years back in the neurology urodynamics as well, that storage pressures are much more crucial because we store for 23 hours and 50 minutes perhaps and pass for only 10 minutes. During storage, if the pressures are high, the kidneys tend to get damaged. Now, in patients with neurogenic dysfunction, typically the patients, their families, they're all focused on the voiding part. They're all asking you the question, do I need to put a catheter? Will I be able to pass urine? But everybody's focus has to be on what's happening during storage, because if storage is not good, regardless of what's happening during voiding, patients will damage their kidneys. And we have patients who've been doing CIC faithfully 5, 6, even 7 times in a day, and they've damaged their kidneys, despite having been under the follow-up of the right department. And that can happen because the storage pressures are not taken care of. So during storage, you can look for phasic contractions called NDO, or neurogenic detrusor overactivity, poor compliance, which is particularly bad. Why is poor compliance particularly bad? We feel that the proportion of time that the patient spends with high bladder pressures is crucial for kidney health. So we know that the kidney does not have a good pumping mechanism for the urine to come into the bladder. It's a low pressure system. So the moment the bladder pressures are high, it impedes drainage. So to get hydronephrosis or damage to the kidneys, you don't need reflux. All you need is that the pressure in the bladder is high. The pressure in the bladder is high. All these changes, consequential changes will happen regardless of whether reflux is there or not. So the reflux is never important in a secondary reflux. It's the bladder which is important. And hence, if somebody has kidney damage because of a bladder issue, reimplanting the ureter is almost never necessary. It doesn't do anything. So you can see, and putting a stent also is never necessary. And in fact, putting a stent would even more faithfully conduct the bladder pressure to the kidneys. So often we find patients with upper tract changes because of the bladder, and somebody's put stents on both sides. That's exactly counterintuitive of what you would get is the exact reverse of what you want. You would conduct the pressures on the bladder even more effectively into the kidney, right? So you can see here, this is a patient in whom, as we fill the bladder, the pressure is progressively going up. This progressive rise in pressure is called a poor compliance. Okay. So this poor compliance is bad for the kidneys. There is something called the detrusor leak point pressure. That's the pressure at which this leakage starts happening. There are many misconceptions, and a lot of people will tell you 40 centimeters of water is unsafe. That's all. It's a very misunderstood concept. Number one, we know that especially children, but even adults will damage their kidneys at much lower pressures, even 20, 25, 30, enough to damage the kidneys. And second, these numbers are important, not in isolation. So if you get high pressures, it's unsafe for the kidneys, but a low pressure is not safe for the kidneys. So if somebody has secondary reflux, this compliance will become perfectly normal because of the secondary reflux, but the kidneys are going to get knocked out. So the pressures will look perfectly fine. So you cannot interpret the urodynamics in isolation. And in neurogenic patients, especially, a video study is crucial, because on the video study, you'll pick up all these things. Is there a diverticulum causing a pressure pop-off? Is there a reflux causing trouble, so that you're not interpreting the pressures correctly, and so on? Okay. I think I'll stop with this. If there are any questions related to what I presented so far, we can have them. And then perhaps, Dr. Saibani, you can present your cases and we'll discuss the cases one by one. Will that be okay?
Yes. Sir, questions after all case discussion?
Yeah, of course.
Okay. I request all the audience to put your questions in Q&A box or chat box. This is the first case, sir. A 10-year-old female with neurogenic bladder with urge incontinence, presented with urinary tract infection. She has storage difficulty, urgency and frequency, and she has having voiding difficulty. Ultrasound showed bilateral hydroureteronephrosis with thickening of the bladder, and her creatinine is 3.6, and she is on CISC for 5 years.
Okay, okay. Can I stop you? Yeah,
Okay.
we'll just take a look at just for brief moment we'll discuss, because ultimately the clinical context is important rather than the tracings. Okay. Now,
Okay.
in any patient with neurogenic dysfunction, if you're getting recurrent urinary tract infection, that's a red flag for a lower urinary tract which is not managed perfectly. So getting urinary tract infection, so you expect, let's say, 1 episode of infection in a year or something in somebody on CIC, that much is okay. But if you're getting repeated urinary tract infection, the first thing that should go to the mind is that the bladder pressures are not managed perfectly. Because if the bladder is managed well, usually infections don't happen. And this is reflected in, you do an augmentation cystoplasty on a bad bladder, and infection rates dramatically come down. So any infections is a warning sign. The other thing here is that in a patient who's having urgency frequency is on CIC and hydronephrosis, my question would be, is this patient on an anti-muscarinic or some drug for storage? Because as we just discussed, CIC is not going to sort out the upper tract problem. The upper tracts get damaged primarily because of storage. I mean, obviously binding is important, but storage is crucial. And what we don't have from this history is what was being done to address storage. Okay. One more thing. If a patient presents like this, what we've seen is at any time, especially in a child, even if it's, you say, let's say this is a congenital problem. So if it's congenital, it's 10 years late, right? But even if that is the case, it's still worth putting a catheter to see what happens to the kidneys. Because even at this stage, if you put a catheter, in some patients, unpredictably, you'll find an improvement in their eGFR. And even if you have a small improvement in eGFR, it could translate into, let's say, 1 kidney less over a lifetime for a child in terms of transplantation. And of course, as nephrologists, you know that you should be discussing in terms of eGFR. That's important rather than just, especially for children, rather than just creatinine. Okay, yeah, go ahead.
This is the recording of filling phase results. Is it okay, sir? Shall I keep the graph?
We'll go to the graphs because most of the times I would say you don't need to bother too much about those numbers. Let's just take a look at the graphs. Okay. So from what we discussed earlier, let's take a look at what we've seen here. So this is like an 11-year-old study. I can see you've really got an old archive with you, right? This is from 2013. Yes. Okay.
Yes, 8 years back.
Right. So
10 years back. Yes.
I hope I will still agree with myself. Okay. So what we see here is the capacity is about 100 ml or so. I think from what I can see here, and that for a 10-year child is definitely low. So you know the cough formula, which is a simple way of calculating the expected capacity, age in years into 30 plus 30. So at 10 years, you'd expect about a 300 ml or so almost an adult capacity, and this is not that. The other thing you're seeing is as the bladder is being filled, the pressures are rising. You're also seeing on top of that phasic rise and fall. So reduced compliance, detrusor overactivity, reduced capacity. And then when the patient is told to pass urine, she strains, but doesn't generate a detrusor contraction and passes with a slow flow. You can see a small amount of urine has come here and she's left a large residue. So she has a small capacity, poorly compliant bladder with detrusor overactivity, acontractility during voiding by abdominal strain with a large residual. Now, at that time, we were not doing video studies, and hence you don't see what's happening. So we really don't know in a patient like this whether the pressures we are seeing are underestimates or not. So let's say if on an MCUG, which you can combine with this to get most of the information, if there's a large diverticulum, or if there is large volume reflux on one side, then these pressures, which are already bad, would be in fact much worse because you would be underestimating those pressures. So from, yeah, go ahead. Yeah.
Which is the graph for capacity, sir? Capacity.
Oh, so if you look at the last line below, where it's written 20, 40, 60, 80, can you see that? The last line at the bottom.
EMG, above EMG.
No, below EMG.
Below EMG. Okay, okay.
20, 40,
yes,
60, 80. So it's about 100 ml. They'll also be in the volume infused line if it's there. Volume infused is the second last above the EMG. It should be there, but because this printing it's very faint. It's not a very good quality of photograph, so it's not being seen. You know? Okay.
Okay.
So let's say this patient. So the question from a nephrologist perspective is what's to be done.
Yes.
Now, the important question would be: is this on therapy or off therapy? So if this patient is not on therapy, let's say first time patient is presented, and this is the presentation. Number one, indwelling catheter. See does the GFR improve or not. Then start antimuscarinics. Put the patient on CIC. Now, if the patient has come on a catheter, then these pressures can be spuriously high because of catheterization. So if patient has 6 months of catheter, then you do the test, you can get all these storage abnormalities as an artifact just because of a long-term catheter. So you have to interpret it in the right context. So I'd put an indwelling catheter, see whether the kidneys improve, start antimuscarinics, put this patient on CIC. Now, if this patient has already on therapy, and this is what you're finding, that means full dose of medication, and this is what you're seeing, this patient, medical management is not sorting the patient out. So now you have a choice of what to do. And for a patient like this, the odds are that the patient will require an augmentation. Now, ideally, the augmentation should have been done with the GFR better. So most of the data that we have in augmentation is primarily for patients with either no renal insufficiency or low degrees, low stage CKD. High stage CKD carries certain consequences. And then you probably have to time this now as to when to do it, perhaps shortly before the transplantation rather than after. So this is unsafe for a transplant.
So first we have to do augmentation, then only proceed with the transplant.
So assuming that this is on therapy, and this is a follow-up study, and this is what you're finding, then such a patient is likely to require an augmentation. And because the GFR is pretty low, and the odds are, even if you augment right now, you're not going to change the natural history of disease. And since augmentation carries certain complication rates, and it may be ideal to plan it now around the time of the transplant. So do the augmentation around that time, and then the patient goes for a transplant. But this needs to be sorted out before the transplant. You can't sort this out after. I mean, you should not leave it for after, because the risk of doing a bowel-related surgery for the bladder, that means an augmentation, would be much higher with immunosuppression. Okay.
So final impression was severe detrusor overactivity during filling phase, a contractile detrusor during voiding phase, reduced compliance and capacity, advise CIC to be continued and escalating the dose of anticholinergics. Now she is stable with CKD stage 4 with creatinine of 2.4.
Yeah, fair enough. So many times we find patients who present like this, once management is started, if they were not on management, sometimes they can stabilize their GFR for long periods of time. Obviously, ultimately, they will end up with end-stage kidney disease. But sometimes, many times actually, you'll find a stabilization in their GFR for a substantial period of time. Okay.
Sir, before this case, there are two questions, sir.
Go ahead. Is it there? Is it in the chat box? No, I don't see it. Oh, there is. Hold on.
Q&A question.
How much GFR improvement? So we really don't know. So if we are lucky, so let's say there are patients who come with a creatinine of 2.4, and in the patient is 1 year, let's say, neurogenic bladder because of a spina bifida, and the child comes at the age of 6 months, bilateral severe hydronephrosis, creatinine of 2. The GFR is extraordinarily low for a 6-month-old child. But you put an indwelling catheter, it might come down to 0.3 for all you know. But if you're unlucky 10-year, 11-year-old child with a congenital problem, you may have no improvement in GFR. So it could be the entire range from no improvement to full improvement. So this is not dependent on catheterization, antimuscarinic. What's important is how much of this was a reversible thing and how much was not, and that only time will tell. So just because it's more than 3 months or 4 months or whatever from the time of onset of their problem, I wouldn't label it as chronic and would not write off the kidney. I'd at least give it one trial. And we have published data on this, that it shows that patients who have a catheter placed in the beginning, despite having advanced chronic kidney disease, some of the patients will improve.
Sir, another question. So all patients who come with bilateral hydroureteronephrosis need catheterization irrespective of duration of obstruction?
So I would say if the patient has bilateral hydroureteronephrosis with reduction in their GFR, substantial reductions in GFR, and have never had a trial of indwelling catheter, the answer is yes. But if there's no reduction in GFR, sometimes, let's say it's a correctable problem. Sometimes patients may have bilateral hydronephrosis, GFR is fine, they've got a primary bladder neck obstruction. We might sometimes take a decision to just primarily go ahead and operate the patient. But you have to balance between what are the risks of doing something like that vis-a-vis what is the expectation. But in general, GFR reduced, bilateral hydronephrosis, never had a trial of indwelling catheter, the answer is yes. Duration of radiological reversal of after catheterization. I'm not sure exactly what Kirtana means by that question. So after how much time? So the anatomical hydronephrosis may not go away. What we are looking at is functional improvement. So I would not monitor so much. When I put a catheter, I'm not looking at repeating ultrasound scans. I'm looking at repeating creatinine tests to check what's happening. So morphology of the kidney may be imprinted. You may get some reduction, but it may stay hydronephrotic lifelong. But you may get functional improvement the moment you go to catheter. There will be subtle changes, obviously, in the hydronephrosis, but sometimes it's very difficult to document. How long should you put the catheter? I'd say at least 2 to 3 weeks. What are your views, pre-transplant high-grade reflux? So there are very clear indications for nephrectomy in a pre-transplant reflux situation. So it's not a default option, and you should be following all those textbook indications, right? For today's talk, what is more relevant is which of these patients require a urodynamics. And I would say if the patient has reflux and has any lower tract symptoms, so there's a checklist that you should be going through. Are there lower tract symptoms? Because if there's lower tract symptoms, then the reflux could be secondary. You don't expect lower tract symptoms in a primary reflux. Are there morphological changes in the bladder? Bladder wall thickening, diverticuli, things like that. Are there bony changes on the X-rays? So many of these patients, when you do the MCUG, there must always be a plain film. If there's no plain film, you will miss a sacral agenesis. And I've shown that slide in previous presentations. Patients with chronic kidney disease, patient with bilateral hydroureteronephrosis due to reflux, operated once, so recurrent reflux, operated twice, another reflux, chronic kidney disease. Out of 3 MCUGs, no plain film. And when I examine the child, there's a short gluteal cleft. We send for an X-ray and the whole sacrum is missing. Right. And you can see subtle changes in the bladder, which should have told the first surgeon itself, not just the second one, that this was actually secondary reflux. Okay.
Sir,
Okay.
for 2 months, we'll keep Foley's. After that, we'll keep
Not 2 months, 2 months.
CIS.
2 to 3 weeks should be enough.
2 to 3 weeks. Okay.
So, I mean, so let me put it this way. There's no set time duration. So if somebody has advanced renal failure, I would keep the catheter until the GFR is improving.
So what is the frequency of CIS you advise?
So for patients who have severe lower tract dysfunction, by and large, the kind of patients we are talking about who would be fitting into your nephrourology kind of a presentation, it would usually be a full CIC of 5 times a day. So this is assuming that they have normal urine volumes. So patients who have very high volumes or patients who have chronic kidney disease and oliguria may not require 5 times, or 5 times may not be enough.
Why we see some unilateral hydronephrosis in bladder outlet obstruction?
So that depends on the specifics of the compliance of the upper tract on one side, other side, and so on. So you may not get bilateral in all patients. And it's possible that if you wait long enough, it will become bilateral on both sides. But it might just be that one side was more vulnerable and became hydronephrotic first. But the important thing is you don't need a reflux for a damage to happen. But we do feel that you need a hydronephrosis for a damage to happen. So long-term damage is unlikely without a hydronephrosis.
18-year-old boy with PUV, lost to follow-up for 4 years, came with severe uremia during dialysis, has good output of 3 liters. Ultrasound showing bilateral hydroureteronephrosis. Should we catheterize him as he was having output of 3 liters?
So 2 things. One is 3 liters is not a good output. 3 liters is a bad output. You don't want a 3 liter urine output for any patient who's got a lower tract problem, anybody for that matter. So 3 liters especially is a patient who is probably either having a concentration defect, or if he's in chronic kidney disease, was he even having 8 or 9 or 10 liters? Was it a wolf, some sort of a DI or something? But if the patient had a PUV, that's very unlikely, I guess. Or is the patient habitually drinking a lot of water? But a 24-hour urine volume of 3 liters is a recipe for causing more trouble to the kidneys. So that's one of the things we always look for in these children. What's the 24-hour urine volume? And 3 liters is too much. Now, in terms of catheterizing, for the reasons I just told you, the answer is yes. You put a catheter to see whether there's some recoverability and function possible, and once in a while, you'll be pleasantly surprised.
Sir, if a child has a, sorry ma'am, I'm interrupting. I have a small question. Sir, if a child has a neurogenic bladder at birth or early age, they come to us, usually we say that wait for a certain age and don't intervene like according to the guidelines and all. If the child has bilateral hydroureteronephrosis at birth, some expected neurogenic bladder. So usually
So number one, the guidelines recommend for congenital. So congenital is typically we're talking of spina bifida or anorectal malformation. Guidelines recommend all management to be started at birth.
Yes, sir. But that management is not like surgical. I mean, only they say to wait,
No,
or is it
it's
something?
not a question
Not
of
the spina bifida, sir. I mean,
no, I'm not talking of the spine part. I'm talking of the bladder part.
Yeah.
All the management has to start at birth.
So does that mean that we need to do this UDS also at that time itself?
Yes. Even so, especially children are very vulnerable. So
Okay.
all guidelines recommend urodynamics to be done as soon as the child recovers from the spine surgery. Children are particularly vulnerable. And we have a long list of children. Literally every 10 days, I see one child where just 6 months or 1 year at the time of birth is enough for chronic kidney disease to set in. Right? So guideline recommendations in spina bifida, urodynamics to be done the moment the child has recovered from the surgery.
How long does it take to convert obstructive uropathy to obstructive nephropathy?
Again, there's no such set time, but all I can tell you is it won't happen in one day clearly. But children especially are very vulnerable. So it depends on, number one, how severe is the disease? And number two, how vulnerable is the patient? So if you have a severe disease in a vulnerable patient, I would say even 6 months is enough for the onset of chronic kidney disease. And you may not notice it at that time. So what is very important, so sometimes you find inexplicably that they seem to be doing well, GFR is fine, and still they get into renal failure later on. And one of the things, so many of the things are in your domain and you would be able to answer better. But one of the things that happens, let's say spina bifida. In spina bifida children, creatinine GFR is a poor estimation. So either you've got to do a measured GFR at a baseline by, let's say, for instance, doing a nuclear scan and seeing both the kidneys, or you need to do a cystatin-based test. But doing a creatinine GFR in a patient who has got poor skeletal mass in the lower half of the body is going to be highly misleading. Right? So, so to answer your question, high-risk neurogenic dysfunction, typically there are three which which are high risk based on just the label: spina bifida, anorectal malformation, spinal cord injury. Two of these are congenital. So in these three conditions, you assess the patient early, because delays are enough to cause trouble, especially if, let's say, they've got detrusor sphincter dyssynergy and they're voiding through that high pressures, they'll knock off their kidneys very rapidly.
How to monitor neurogenic bladder patients post-transplant, sir?
So you assume that you have sorted out the storage before you have done the transplant. So in some situations, and we need to move on to your other cases if you've got to finish in the next 17 minutes, but we assume that the storage part is taken care of before the transplant, because sorting out storage post-transplant is a disaster. But voiding, sometimes it may be fine. So there's some situations where you have a doubt, is the patient having a primary bladder neck obstruction? Sometimes I may tell you, okay, go ahead with the transplant, we'll see later. Sorting that out is not such a big issue. But a storage pressure problem sorting out post-transplant is not on. So we have to pick that up before the transplant. How do you monitor? You'd monitor in all the same ways. But one thing I would say is all these patients who are having neurogenic dysfunction or lower tract dysfunction, not just neurogenic, if they're on CIC, you can't afford a 3 or 4 liter 24-hour urine volume post-transplant long term. As a nephrologist, you've got to target a lower urine volume. Because if the patient is going to produce 3 liters or 4 liters in 24 hours long term, putting them on CIC is a challenge. They'll keep, so either I've got to tell them do your CIC 10 times or 15 times in a day. And obviously that exponentially increases the risk of sepsis. It also runs the risk of over distending the bladder, because the patient will not be compliant with such a high frequency of CIC. And so the odds of sepsis will be there. And if the bladder over distends repeatedly, the graft hydronephrosis would happen. So you need to target a lower 24-hour urine volume for these patients, which you might find I often write and send, that post-transplant target a lower volume. Let's move on to some of the other cases, because otherwise you'll run out of time.
Okay.
We'll keep discussing the questions and answers all through the time, right?
Okay, sir. Coming to case 2, a 16-year-old male boy, symptoms of urgency and frequency since childhood with no voiding symptoms. diagnosed as CKD ESRD, worked up for transplant, father as the donor, ultrasound abdomen showing bilateral hydroerythronephrosis with creatinine of 9.2, and MCUG was showing no reflux. And this is the graph.
Right. So this is a slightly difficult situation. The patient, so it's understanding what is happening in this patient is easier if the patient is not oliguric. So if this patient has come with an end-stage kidney disease and he's oligoanuric, then interpreting the urodynamics becomes more challenging. You can't do non-invasive testing to get an initial picture very well and so on. So there are challenges there. So if you see the presentation, clearly this patient seems to have had storage symptoms. Didn't have voiding symptoms, but that doesn't necessarily tell you that the voiding was normal, because it's many patients who have never passed urine well may not know what's normal. So they may not be able to understand that there's a problem. So let's go just by the study which is in front of us. Okay. So in this study, again, a non-video, because that time we are not doing video studies. You can see here that during storage, capacity is normal, 340 ml has been filled in. There's not much of a rise in pressure during filling, so the compliance is fine. There are phasic contractions seen, diffusive activity. Now, assuming that we have a MCUG, because this is not a video, so MCUG is crucial, doesn't show reflux, there is no large diverticulum, etc., no other pressure vent, then this storage is safe. So this is a safe storage. The voiding for a child is a child. So this is 3 and 4, kind of old teenage child. So this voiding only from this trace is little difficult to interpret. There's a slightly higher pressure with a flow which looks fine and the bladder is emptied completely. This may be normal. This might just be a catheter artifact. So I would look at the other cycles of testing and the tube free flow to take a final decision. On this cycle, it looks like obstructed, but it could actually be normal as well. Do we have the other cycles? Same mild elevation and pressure with a near normal flow. Do we have a tube free flow? Okay, we don't. Okay, so let's see what the final impression was. Diffusive activity, high flow. So whether this patient is obstructed or not would depend on something. So just go back one slide. So there's a slightly higher pressure here. Now, how I would interpret what is happening here is on the basis of the rest of the clinical history. Does this patient have hydronephrosis? Right? What's the right? Has bilateral
He is having bilateral hydroerythronephrosis.
Okay. Now, is this and what's the patient's urine volume? Because as I said, let's say if this patient is producing 4 liters of urine, that might explain the hydronephrosis. Okay. But if this patient was not having large urine volumes, there was a bilateral hydronephrosis, there's no reflux, as you said, on the MCUG, and the patient consistently showed somewhat elevated pressures, I would look at the go back and see the MCG. Today, I would do a video study and try and understand whether there's a primary bladder neck obstruction. It's possible that this patient has a primary bladder neck obstruction, a high flow obstruction. But it's difficult for me to explain the entire presentation to the nephrologist with end-stage kidney failure just on the basis of this urodynamics. So there's something not captured from the urodynamics.
So on follow-up, he underwent transplants, but a donor kidney had cortical necrosis because donor kidney got 2 arteries, and now he is on CAPD. Coming to case 3, a 20-year-old male diagnosed as PUV underwent vesicotomy in 1990.
Just one moment. I'm just trying to see whether we can give a coherent explanation to what happened to case 2. Now, so depending on how much is the hydronephrosis, so let's say there's a mild bilateral hydronephrosis seen in this patient, it's possible that they may have been just, because as I said, it's difficult for me to explain the renal insufficiency in this patient based on the lower tract dysfunction, regardless of the presence of urgency in the history. So it's possible, let's say that there was a bilateral reflux to start with. The reflux is now resolved, but it's left behind a reflux nephropathy, etc. So it's very difficult to just explain why the patient will have end-stage kidney failure with this urodynamics. It's not fitting in, as I said. Okay. So I would look for an alternate explanation. But there's a possibility that this patient does have a primary bladder neck obstruction component. But is that component enough to cause upper tract changes and CKD? My guess is no. Okay. Right. Let's go to the third case here.
20-year-old male diagnosed as PUV underwent vesicotomy in 1994. and closure of vesicotomy in 2008, presented to us as ESKD in 2011. Neurological examination was normal. Ultrasound showing bilateral hydroerythronephrosis. Creatinine was 7.2 on maintenance hemodialysis. Worked up for cadaveric transplant. This is the graphs.
Okay, so what we are seeing here, the capacity is okay, but the compliance is not very good. You can see as the bladder is being filled up, the pressures are going up. Now on the MCG, there's no
Which pressures we are seeing, the detrusor pressure.
third line. Yeah, we always look at the detrusor pressure line. I mean, we see the other lines only in context of trying to understand what's happening here. Okay, you can see a progressive rise in pressure as the bladder is being filled. End fill pressure seems to be somewhere around 50 centimeters of water, 40-50 centimeters of water, which is high and enough to explain upper tract changes in this patient. Does the patient have reflux as well? No. We don't know. So if the patient has reflux, as I said, this will also be an underestimate of the pressure, but this is unsafe and enough to explain the upper tract problems. Now, interpreting this again is dependent on the urine volume because this patient is advanced kidney failure, kidney disease. So if this patient is oligoanuric, then what you are seeing here may not be a true reflection of what the bladder actually is. So a patient who is anuric, for instance, and you do a urodynamics and you find this may be perfectly fine. And the way to understand would be that the next cycle, you would never leave at one cycle. You would do 2, sometimes even 3 or 4 cycles. And if you find the pressure dropping substantially on second, third cycle, that's a sign that the bladder is in disuse. So when you're recycling, then you're finding the pressures are dropping. So many of these patients who are anuric, you need to be careful in labeling this as a bad storage. And then, of course, in voiding, the patient is not showing avoiding any detrusor contraction. So whatever void attempt is there is all by abdominal strain. So this patient has a poorly compliant acontractile bladder. So in terms of making this patient safe, assuming that this is all representative, whatever pressures you are seeing here, you first put the patient on antimuscarinics, put the patient on CIC, reassess the bladder before you plan for a transplant.
Reduced complaints. So filling phase, no detrusor overactivity, complaints decreased, capacity normal, unsafe end fill pressure of 31 centimeters, voiding phase, abdominal strain present, acontractile detrusor, slow interrupted flow, PVR is significant, poor compliance, capacity normal, acontractile detrusor.
Okay.
So treatment advice, anticholinergics, CIS.
So for managing storage, the tools that we have under our belt is the standard management is antimuscarinics. Okay. There is some data that mirabegron might help, but you don't have good quality data. So in some of the guidelines globally, mirabegron does not figure. In some guidelines it does. But there are not many studies examining pressures in terms of safety of pressures and mirabegron. So mirabegron is good for OAB or overactive bladder non-neurogenic, but whether it improves safety in patients with an unsafe lower tract, that question is not well answered at this point. So antimuscarinics is the mainstay for storage. For patients who don't respond to antimuscarinics, if they have purely phasic contractions, neurogenic detrusor overactivity, those patients have a good response with botulinum toxin. If the patient, or you could even do a sacral neuromodulation. But for patients, for the neurogenic group, you wouldn't do sacral neuromodulation because that's off-label. So a botulinum toxin is effective for phasic detrusor contractions, but botulinum doesn't work well for just poor compliance. The next thing about botulinum is not really, you can say, a kind of an approved management plan for somebody who's developed kidney problems. So when you give botulinum, the effect wears off in a certain amount of time. You don't have good markers to tell that it's worn off. What happens if it keeps wearing off every 6 months or 8 months and there are 2-3 months of high pressure or lifetime? We don't know. So if there's upper tract problems, poor compliance, I would normally manage the patient with botulinum. Okay. And if these two don't work, then obviously it's augmentation cystoplasty.
Coming to case 4, a 33-year-old male diagnosed as ESRD in 2011 on MHD had significant voiding difficulties and storage problem. Worked up for cadaver transplant, ultrasound showing bilateral contracted kidneys, creatinine of 8.2, MCEG showing grade 1 reflux on left side. This is the graph.
So here you can see Capacity looks fine. It's about some 300 ml or so that has been filled in. As we fill the bladder, there's some reduction in compliance. Okay. And when the patient tries to pass urine, there's an elevated pressure and there's a slow flow. Now, I won't go into the details, but this amount of elevation that you have for this flow is not as much as it should be. So this patient is obstructed definitely, but is also having a component of a weak bladder as well. So there's an obstruction with underactivity and a poorly compliant bladder. Sphincteric EMG, which you're seeing in all these records, is rather unreliable. So these days we have switched to completely to using video in all these patients, and we would see on a video. But in a 33-year-old male, the first thing that would come to mind is primary bladder neck obstruction. So the odds are that this patient has primary bladder neck obstruction, an element of underactivity, and some element of poor compliance. We don't, and there's a little bit of, there's some reflux happening on the MCUG, as you have mentioned. On the MCUG, the other thing to see would be in the voiding phase, what's the bladder neck configuration? That may give you an answer as to what the underlying diagnosis is. Okay, so let's see what we have. What was the conclusion at that time? The same findings you can see in this one also. So what I've written here is consistent picture with functional bladder neck obstruction, what we call a primary bladder neck obstruction now. Okay, but the compliance is better here, you can see. So in this cycle, so we always look at other cycles also. If you fill too fast, the compliance doesn't look good. So you can see here, the one which shows the better compliance is typically the more representative. But remember, this patient also has reflux. So it's possible that the reflux is causing a spuriously better compliance than it actually is, especially the volume is high. Okay, the same consistent findings, slow flow, coordinated sphincter.
The final impression is no detrusor overactivity, compliance is reduced, capacity is acceptable, unsafe end pressures, voiding phase high pressure detrusor contraction with very poor flow. Pdet max was 62 and maximum flow rate was 3 ml per second. Sphincter coordinated, complete voiding. So functional bladder neck obstruction, advised alpha blocker. If no improvement, functional bladder neck incision.
So we call it bladder neck incision. Now, from a nephrology perspective, the important question, even from a urologist perspective, the important question is, are the kidneys damaged because of this? Or is this just incidental to what you have found? So the answer to that question will come by looking at the ultrasound scans done at the initial diagnosis. So when this patient presented at the time of reasonably good volumes, at that time, what did the ultrasound scans show? Now, if this patient had bilateral hydronephrosis at that time, then it's conceivable that what you're seeing now is a consequence of what happened at that time. But this patient doesn't have hydronephrosis now from what I recollect. And let's say the previous ultrasound scan, it may be because now the urine volume is low. But let's say 2 years, 3 years, 4 years prior to this point of assessment, when the patient had a good urine volume, there was no hydronephrosis then. Then in that case, this chronic kidney disease is a separate chapter, and the primary bladder neck obstruction is just an incidental finding. Okay.
So follow-up underwent transplant with cadaver as the donor. Now on alpha blocker, creatinine is 1.2.
So this suggests that the primary bladder neck obstruction is incidental. The amount of improvement you get with alpha blockers for patients who have bladder outlet obstruction is very modest. Somebody who would damage the upper tracts because of a lower tract problem is very unlikely to get sorted out with an alpha blocker and then be able to have a transplant and do well post-transplant without undergoing surgery. So the odds are, and you said there was no hydronephrosis, that the CKD was not related to the lower tract problem, but the patient had an incidental primary bladder neck obstruction as well.
Coming to case 5, a 13-year-old male had RTA at 3 years of age, paraplegia, neurogenic bladder, voiding difficulty, storage symptoms, ultrasound showing bilateral hydroerythronephrosis, MCUG was normal, creatinine is 6.2.
Okay, so just one point in these patients who have spinal cord problems, important to see the level of the injury. And if they have anything in the cervical area or the upper thoracic area, then you must take a history to elicit whether the patient has autonomic dysreflexia. Is the patient getting sudden onsets of severe headache, sweating, and so on? And you can get very high rises in pressure, which can cause a stroke, and the patient can even lose life. So extremely important to take a history for autonomic dysreflexia. The commonest source which triggers the autonomic dysreflexia is the bladder, followed by the bowel. So overdistension of the bladder and overdistension of the bowel are the commonest reasons to get autonomic dysreflexia. And especially if they are quadriplegic, then you must remember that baseline blood pressure in a quadriplegic is much lower than usual. You would expect, say, 90/60 in the average quadriplegic. So if they have 130/80, that is actually a hypertension for a quadriplegic patient. So important to check in terms of their developing autonomic dysreflexia because it's a life-threatening condition. Yeah, so go ahead.
Okay. So this is the graph, sir.
Yeah. So again, you can see here a small capacity bladder. Look at the bottom where we are seeing it's about 100 ml or so that's been filled. You can see
60 mm.
you can see a very high pressure as the bladder is being filled up. Okay. And so this is a reduced capacity, poorly compliant bladder. And you can see the end filling pressures are very high. And when the patient tries to pass urine, there's an acontractility. It's trying to strain with his abdomen, is not able to pass. There's no detrusor pressure. So small capacity, poorly compliant acontractile bladder with unsafe storage and resulting secondary chronic kidney disease.
Same, sir. Filling phase, no detrusor overactivity, poor compliance, small capacity, unsafe end filling pressure, voiding phase, abdominal overactivity, acontractile bladder, acontractile detrusor, started on anticholinergics, CISC, follow up on CISC and anticholinergics, creatinine decreased to 2 points.
So somebody had asked a question in the beginning, how would you follow? So it depends to a certain extent. So there's a baseline assessment, and the baseline assessment would determine what you want to follow. But assuming, because we are doing a nephrology session, that these are all likely to be high risk lower tract dysfunction, otherwise they won't reach the nephrologist. So in a high risk patient, especially, first assessment, see how the bladder is. The bladder or lower tract looks unsafe. I would start therapy. Call the patient back with a CIC diary. That's absolutely crucial. You cannot manage a patient with lower tract problems without a CIC diary record. On the CIC diary, if they show that the average mean CIC volumes are low, or if they show that they are leaking in between, then in that case, you would escalate their antimuscarinic dose until you reach the ceiling dose, or the diary looks fine. At that point, you would repeat the urodynamics on medication to see whether the lower tract is safe. If it's not safe, and if you have not reached the ceiling dose of antimuscarinics, you step up the dose. If you already reached the ceiling dose, you would see, is this patient amenable to botulinum toxin? If yes, then botulinum toxin. If no, or if upper tract damage is happening, depending on the setting, some of these patients may require augmentation. But augmentation should be a last resort, should be very rare. So, I mean, we see so many neurogenic dysfunctions. I hardly augment any of them. Augmentation is a glamorous surgery followed by heartbreaking consequences in the long term. So it's fine to do the surgery, but these patients unpredictably will die on you. It's a procedure which carries significant perioperative morbidity and carries an unpredictable long-term mortality. Patients will have spontaneous bladder rupture because they don't have a sensation. They don't catheterize for a few hours. Sometimes unpredictably the bladder ruptures, or due to the catheter trauma it ruptures. It doesn't get picked up in time because the sensations, etc., are reduced. And just 24 hours, 36 hours of urinary peritonitis in a patient who's been augmented is a recipe for death. So, and this is just one of the problems. It's a messy procedure. So patients have stone formation is common. Some patients keep coming back with huge stones in the bladder. Okay, they have metabolic abnormalities related to it. So there's any number of problems. Rightly chosen patient, it's a life-saving procedure. But it has to be a considered decision. It carries a lifetime of consequences for patients. Right.
Okay. Coming to last case, a 17-year-old male patient diagnosed as ESRD 6 months back, neurological examination normal, by ultrasound showing bilateral hydroerythronephrosis, MCG showing bilateral grade 5 reflux, worked up for transplant as father as the donor, underwent unilateral nephrectomy left side, later became anuric.
So again, in this patient, the key information, because we are looking, is there a lower tract problem? So there's a lot of missing information. So you want to know what's the post-void and the pre-void bladder volume. You want to know what's the flow rate if the patient has a reasonable urine volume. So you'd expect that as a part of the initial assessment, a uroflow, a pre and post-void bladder volume. That's important. And many of these patients, bladder diary is important. But anyway, I'm assuming that, I mean, you have what information you have. So yeah, go ahead.
This is the chart.
Right. So you can see here normal capacity about 380 or 60 ml or something as there has been filled. You can see normal compliance. In the MCG, I think there was no reflux from what he said. So it's normal compliance, no detruse overactivity, normal storage. But you can see as this patient voids urine, it's a very high pressure and a slow flow. Okay. So this patient is obstructed with a high pressure, slow flow. Do we have another cycle of testing to reconfirm? This is a normal flow. So now this is a red flag as to what you're dealing with. So there are several possibilities here. So do we have any other cycle of testing? Okay. So if you find a high, so there are some possibilities here. So if you have a high pressure, very slow flow, and if the urine flow, I mean during the pressure flow, and if the uro flow that is done and is showing a normal flow, especially if this uro flow is done post-test, sometimes this may mean that there's a stricture or a partial stricture. So if there's a partial stricturization of the urethra, and then you put a catheter, then when you put the catheter, then the patient gets obstructed severely. The moment the catheter is out, the patient voids well. So really, is this patient having a partial stricturization because of which we are seeing this picture? That's one thing that comes to mind immediately if you see something like this. There are some other possibilities, but there is a mismatch here between what you're seeing on the tube-free flow and what you're seeing in the pressure flow. And that should always raise a red flag as to what the patient's problem is, because sometimes it may be an artifact what you're seeing on the pressure flow. What have I written as a conclusion? Do we have that?
Yes, sir. So filling phase, no detruse or overactivity, compliance normal, capacity normal, safe end fill pressure. Voiding phase, high pressure detrusor with slow flow, detrusor of 100 centimeter per water, maximum flow rate of 2 ml per second, severe bladder outlet obstruction, sphincter normal, small residual urine.
Okay.
Impression, high pressure bladder flow obstruction, advised functional bladder neck incision.
Okay.
So
there's something called a high flow obstruction. So conceptually, when you look at flow, it's as if I'm in this room, I'm pushing the door open, and you're sitting outside and watching how fast the door opened. Now, if the door opens fast, you would expect that it's not jammed. But it may also open fast despite a jam if I've pushed very hard from inside. So if the bladder generates a very high pressure, sometimes you can get a normal flow. So there are patients who are obstructed with a normal flow but have a very high pressure. Now, whether this patient has that condition, which is possible, or whether the patient has something else would get determined by the rest of the presentation. So I'm assuming that in this patient, the rest of the presentation matched up. So if the patient complains of avoiding difficulty, and I think this patient did, so the patient complains avoiding difficulty, that suggests that that the obstruction you're seeing is actually there's actually a problem there. Or if the patient has residuals which are elevated with all these findings. So you've got to look at some of the other things. What's the lower tract morphology and so on. So if everything fits in, be careful, but if everything fits in, the patient might be having a high pressure obstruction. And if it's a high pressure obstruction, so the terminologies are not very perfect here, but if there's a high pressure obstruction, we would then look what's the location. Typically, it would be at the bladder neck. So if there's a high flow obstruction at the bladder neck, we would call it a primary bladder neck obstruction, and a bladder neck incision would be the usual therapy for that. Now, I'm not sure whether this patient had a bladder neck incision or had an alpha blocker. If the patient has already had a bladder neck incision, shouldn't really require an alpha blocker. So I'm not sure exactly what, but that's what this looks like. So it could be a primary bladder neck obstruction, a high flow obstruction as well.
So he underwent transplant with father as the donor. Creatinine now is 1.2 on alpha block.
Sure. Okay, now
coming to the questions.
Okay. So you can stop your screen share and maybe you could just look at the questions that are pending, unless the question deals with the patient, which we need to see. Okay.
How long to keep on catheter open? How to monitor new wiping? Does secondary reflux also needs urodynamic studies?
So when you say secondary, it implies that there's a problem with the bladder. Otherwise, you wouldn't call it secondary, right? So there would be clinical clues to tell you it's secondary. And if it's secondary, that means there's a lower tract dysfunction. So a lower tract dysfunction causing upper tract changes typically implies a high-risk lower tract dysfunction. And high-risk lower tract dysfunction does require urodynamics. So if you have a secondary reflux, the moment you use that label, it automatically implies that the bladder is high risk. and hence does require assessment. Yes.
What to do about incidental vesicle diverticuli
So,
seen on others?
so just one moment. So there may be some settings where a reflux does not always require a urodynamic. So let's say, for instance, 65-year-old man has a benign prostatic enlargement and is obstructed because of it and has unilateral reflux because of it. That patient may not necessarily need a urodynamics, but you may not do an MCUG on such a patient, so you may not pick up the reflux. But if you were to do an MCUG on all the men who come at the age of 65 or 70 and check what happens on an MCUG, you would find a secondary reflux in some of them because of their obstruction. But normally you won't do that test, so you don't pick it up. Yeah, go ahead. You were asking something.
What to do about incidental vesicle diverticuli seen on ultrasound done for other indications?
Okay, so I mean, you can, so not all, so in general, a diverticulum itself usually doesn't require anything to be done. So there are some situations, let's say there's a child with a reflux with a paraureteric diverticulum, that's a different issue because you need to treat the diverticulum at the time of reimplanting the ureter. But otherwise, if somebody comes with a reflux and the reflux with a diverticulum and there's lower tract dysfunction, just as with the reflux, typically you just need to manage the primary problem. You don't need to do anything to the diverticulum. But to answer your question, if you find a diverticulum, you would examine to see, is there something which is asymptomatic and getting missed? Often it may not require invasive testing. Should usually be managed. You should be able to get an answer most often from non-invasive testing. But just the fact that somebody has a diverticulum may not be enough for me to do invasive tests or invasive therapies.
Will you surgically correct secondary VUR, especially with recurrent UTI?
So recurrent UTI in a patient with secondary reflux is almost invariably because of the bladder, not because of the reflux. You correct the reflux will come back. We have any number of patients with a recurrent reflux because it's secondary and the bladder is not taken care of. So the infection is a red flag for poor bladder management.
So post-transplant, how do we manage?
It would be very rare for me. In fact, I am offhand trying to recollect when have I ever done a reimplant for a secondary reflux. I can't remember at all, actually. None of our augmentations have been reimplanted. This is almost 150 augments. Yeah, go ahead.
Sir, post-transplant, how do we manage CIC as they have increased output post-transplant?
Precisely. So if you need to get the output down, there's really no option. So I mean, you can't really put somebody who's producing 3.5 liters or 4 liters in 24 hours on CIC. You'll get into trouble. So we need to target a lower urine volume in those post-transplant patients. So in the beginning, they would have a catheter. You'd keep the catheter a bit longer and try and get the urine volumes down. So if the patient is completely dependent on a CIC, let's say a neurogenic dysfunction or something, you've got to get the volumes down. I mean, you can tell them to do CIC more often, find a balance. So we may not get it down to a liter, obviously, but you can't keep the urine volume at 4.5 and that kind of liter volume because you'll get into trouble. Sooner or later, there'll be upper tract changes. The patient gets into recurrent sepsis, all kind of problems start happening. So target a lower volume and tell them to do CIC a bit more often. So kind of try and strike a balance between getting the bladder emptied emptied perhaps a bit more frequently. But remember, there's a consequence to more number of CICs.
Young adult was planned for transplant 4 years back. His creatinine was that time 6 mg. Now, 4 years later, it is 13. Should we catheterize him?
Okay. So this is a judgment call. So I mean, so if you feel that, in some situations, we not always put a catheter to check what happens. But if the patient has come with a chronic retention, so let's say the patient comes with had creatinine of 6, has now come with creatinine of 13, and the bladder is filled to 700 ml with hydronephrosis. Yes, the answer is I would put a catheter. It would be part of the management, and it would also be a check to see what happens. It's possible he gets off dialysis for the next 1 year. Who knows? Even that 1 year may be precious.
How can micturition command be given to children who are not toilet trained?
Oh, so in children, when we do the urodynamics, we are only focused on storage. So I'm trying to get all my voiding information indirectly, and sometimes assuming that about the voiding based on the storage. So a child who comes with spina bifida and has a bad bladder with upper tract dilatation, even has storage abnormalities, you can usually assume that the voiding is going to be abnormal. Almost invariably it is. You can get idea from the ultrasound scan, check their pre and post void bladder volume and so on. So I wouldn't try and get voiding information, say in a 1 year or a 2-year-old child. So you'd need to have at least, depending on individual children, I'd say on an average, children need to be at least 6-7 years age before you can get good quality voiding information, sometimes even older. Once in a while in a younger child, you might. But you can, what is important is storage, because ultimately it's the storage which is damaging the upper tracts. And you can get that information in a newborn.
Any role of desmopressin post-transplant to decrease the urine volumes?
You tell me.
Yes.
I think that's your domain more than mine, right? So do you want to use desmopressin? I mean, is the urine volume more because the kidneys are, why is the urine volume high? It's usually, to my knowledge, after
Because of
the first few
urinary
days,
milieu.
after the first few days, it's primarily because the patient is drinking a lot of water, right? They're drinking water to diuresis. So they are told maintain a high urine volume. So they keep drinking more and more water. To the best of my knowledge, after the first few days when the kidney is settled, it's no longer because of anything. I mean, once the solute load has gone away, I see no reason. You're the better. You'll answer that question much better than I will, right? So I don't think there's any role for desmopressin in a patient who's having a high. Okay, so let me put it this way: it's the other way around. A patient who has a high urine volume, it's a contraindication to using desmopressin. The patient will go into dilutional hyponatremia if you give desmopressin to a patient like this. So desmopressin is only used to reduce the urine volume. So unless I'm not talking of things like DI and all. So desmopressin is used for in situations where patients, let's say, have nocturnal polyuria. You want to reduce the urine volume in the night.
Yes.
For patients who don't have a global polyuria. If it is global polyuria, they'll develop hyponatremia with desmopressin.
5-year-old girl child, small intergluteal cleft, no hair, has occasional bedwetting, but occasional in school complaints of unable to hold urine by the time she reached the toilet. Do we need to evaluate?
Yeah, short gluteal cleft is a warning sign for a sacral agenesis. And sacral agenesis used to be thought as not an unsafe problem. We've reported, I think, in 2017, series of almost 18 or 20 patients with renal insufficiency, many of them. So many of them have high-risk disease. Yes, the answer is yes. So you do basic initial screening, a plain X-ray, an ultrasound scan, Euroflow, depending on what the patient's presentation is.
Sir, does MCUG is needed in high-grade reflux? If required, in what way it will be helpful?
How did you know it's high-grade reflux without the MCUG?
Yes. Sir, can you explain the CMG again for the 6th case?
So you don't know the patient has a reflux without the MCUG, right? So that question is I mean, the question doesn't make sense, right?
Yes, sir. How to manage defunctionalized bladder in ESRD patient before transplant?
So usually nothing is necessary. If the bladder is otherwise normal, bladders can be left defunctionalized for 10 years, 20 years, and you can reuse the bladder if everything else is restored. And if provided the bladder was intrinsically normal, our current understanding is the bladder will go back to normal.
Why BPH will have unilateral reflux? It should be bilateral.
No, we already discussed that you can get reflux on one side. You may get no reflux, but hydronephrosis. So any secondary reflux is actually irrelevant. I wouldn't focus at all. You can get all upper tract changes without reflux. And you have patients in whom reflux is there, but renal function is still preserved. So what we are interested in is there upper tract damage happening because of a lower tract problem? The reflux is incidental.
Which
And that-
anti must?
Sorry. That depends as we described on the mechanics, let's say, of the biomechanics of each side, which may not be exactly the same. Yeah, go ahead.
Which antimuscarinic do you prefer? What does and how frequently would you up titrate?
So so you can use. We know our current data suggests that all antimuscarinics are equal in terms of their efficacy. So you could use any of them. But there are certain things. So in a very small child, let's say 1 year, 2 years old, in those children, there's not much data on many of the other antimuscarinics other than oxybutynin. So purely because we don't have good data in a child who's 1 year, 2 years, then all we would use oxybutynin. In slightly older children, we would now, earlier I would switch to torticolin. Now I would switch to solifenacin, because I think any child above 5 years or so, I'm comfortable switching to solifenacin. Why? So we know that the long-term consequence of antimuscarinics, we have certain concerns, because there's when we use an antimuscarinic, there's certain amount of cross block, you can say, of the M1 receptor in the CNS, and how much impact it has in terms of obvious sedation to some children, etc. That is of course there, but how much is the consequence in terms of, let's say, a child's ability to learn, cognitive function? Those are things we don't understand well. There's no good measure for it. By giving solifenacin to a child, will it happen that, let's say, if the child had the potential to be a genius in maths, they become slightly less competent than they would have been? We really don't know what happens. And there's also a long-term concern in terms of dementia, etc., with antimuscarinics. So use of solifenacin, darifenacin, and trospium, these are safer in terms of, and physiotherapy is safer in terms of the CNS. So I would try to switch to solifenacin, with which the maximum experience worldwide is there in older children. In very young children, I'd use oxybutynin. With solifenacin, there's also an option of dose titration. But otherwise, you could use any of the antimuscarinics. What was the other question?
How to evaluate an anuric child with urological evaluation? What would be the battery of tests not to miss a urological problem prior to transplant?
So a lot depends on what was the assessment before the anuria happened. So were there lower tract symptoms? So in a pure chronic kidney disease related anuria, you don't expect lower tract symptoms. So what were the lower tract symptoms? Was there hydronephrosis earlier? Was there an elevated residual earlier? So you need to be like a detective and go back and search the old records. That's really important. If no old record is available, then a clinical exam, back examination, looking at assessing the bones, looking at the ultrasound carefully, looking at the morphology, and if you have any doubt, at least an MCUG.
Can we go for renal transplant in a child having CKD with uncorrected posterior urethral valve from birth, but underwent fulguration now? Risk of post-transplant UTI?
No, so the fulguration has now already happened. So once the fulguration has happened, that's fine. But many children who have PUV will have associated lower tract dysfunction. So it would be a good idea to assess their bladders before you do a transplant. As I said, storage abnormalities are problematic to correct post-transplant.
If small capacity bladder in ESRD patient, how we go ahead with transplant? Like patients require any bladder opening? Already answered.
So so I mean, assuming that it's not a disuse-related small appearing bladder. So if it's just disuse-related anuric patient, sometimes the bladder just looks small. But if the bladder is actually physically small, you would need to do something. If you don't do something, the patient will be miserable even after the transplant. So, and if you have to augment, it's preferable to augment before.
Does DKD patients going for transplant should have urodynamics to evaluate diabetic cystopathy?
Not everybody. Otherwise, you'd be doing a lot of urodynamics on a lot of patients who are diabetic. So, I mean, they should have features to suggest that they have a lower tract dysfunction enough to compromise the transplant.
Sir, sir, our president, Dr. Jikki Madam, wants to talk with you, sir.
Yeah.
Madam?
Sir, I would like to ask you a few things. But before that, let me congratulate you on a very excellent and knowledgeable talk on this that you have shared with us. Sir, can MCUG be falsely negative at times?
You mean in terms of
The picture not showing a reflux,
oh,
but
yes,
actually there is an existing reflux.
Yeah, absolutely. So I mean, so none of these tests are perfect. So we've seen patients in whom an MCUG shows reflux. We do a video study and we don't find reflux on the day of the urodynamics. We've seen patients in whom there's no reflux on one or both sides on the MCUG done with which the patient has come, and we've done a video study and we find reflux. And you know about it that there are patients in whom you suspect reflux-related nephropathy, and you do an MCG, doesn't show anything, and you do a nuclear cystogram and you find reflux. So none of these tests are perfect, and it's not that you don't pick up the reflux; it's that the reflux doesn't always happen.
Sir, another question. In a high output cases, before planning a transplantation, you said we have to bring down the output.
No, I didn't say.
Will a unilateral nephrectomy help to bring down the urine output in such cases prior to transplantation?
I think most of the patients who have polyuria and renal failure, their urine volume comes down drastically once they go into end-stage kidney disease, is what I find. And I think you
At
probably,
least in a preemptive transplantation,
Yes.
say a child
So I mean, so
with
if
growth problems.
so the odds are that if these kidneys are poorly functioning, the moment the patient has either long-term dialysis or the patient has a transplant, then that usually that diuresis would settle down. I mean, we know patients have very high urine volumes. Once they go into end-stage kidney disease and you start dialysis, their urine volume drops drastically. So I think once you have something doing the dialysis for the child, either a machine or a new kidney, then the native kidney function drops. So I don't think that would be a challenge. But it would be unusual for a patient to be having very large urine volumes and be still fit for getting a transplant immediately. But I mean, be in a position where a transplant is being done. I think the other way around is much more likely, that you've done a transplant and now you have a post-transplant large urine volume with a lower tract dysfunction. And that is a challenge, as I said.
If you are planning for a preemptive transplantation for growth problems to augment the growth, in such a situation, without the urine output falling down, could you do something to bring down the urine output before transplantation?
It is so there's only a subgroup of patients in whom there is a dramatically high urine volume. So I wouldn't be bothered about borderline, renal concentration defect related some element of increased urine volume. Most of those are not like 4 or 5 liters in a day. So those kind of patients, I wouldn't bother. I just go ahead with the transplant.
Sir, in a post-hoc sequelae with a small capacity bladder, will augmentation cystoplasty help these people because it is problem with storage?
Oh, yes. So, I mean, so patients who have a fibrotic small bladder, they need to have an augmentation. Some of those patients already have chronic kidney disease. And again, all the concerns in terms of their GFR and progressive renal disease are important. And once you augment them, these patients need to be on CIC. So it is important to teach them CIC before the augment to make sure that they're compliant, because even one day of non-compliance is enough to kill a patient.
Thank you, sir.
Right, ma'am.
Thank you for the enlightening lecture and answering the questions also. Thank you so much.
My pleasure.
Ramakrishna sir. Sir, your comments?
Yeah. No, I don't have comments. Thank you, sir. Thank you very much for your elegant discussion about practical experience. We all delightfully learned a lot from your lecture.
My pleasure. Thank you so much.
Shivakumar sir.
No, simply superb.
Thank you so much.
Simply superb.
Thank you so much, sir.
Very informative. Thank you, sir. God bless you.
My pleasure. Thank you so much. Bye. And I thank Dr. Saivani for taking so much of pains and really making sure that I did this. And I'm really sorry I troubled you so much in giving you this, fixed scheduling this. But anyway.
No, sir, it's our privilege to have you on our platform, APSN.
My pleasure. Okay. Thank you. Bye and good night.
Thank you, sir. Bye. Good
Thank
night.
you.
Bye-bye. Bye. Thanks, Saivani. You're great.
Thank you, sir. Thank you very much, sir. For the
Thank you.
Bye.
I thank all the attendees. Despite of your valuable time, you have attended and made our webinar a great success. Thank you all. Thank you, sir.
Thank you, Saivani, for arranging this, an excellent enlightening program. And I find the participant number also swelled up so much. Leave webinar.